Hello, everyone, and welcome to today's webinar on female athlete hip injuries, hosted by Arthro School. I'm Haylee Borgstrom, a primary care sports medicine physician at Mass General Brigham, and I will be moderating today. I have the absolute privilege of working closely with all of today's speakers, often in collaboration through our women's sports medicine program here at MGB, where we really focus on the multidisciplinary care of female athletes. For those of you who have not attended a similar webinar in the past, today will be organized into a series of short talks, 8 to 10 minutes, followed by a live Q&A panel discussion at the end. So please do send in any questions that you may have as the lectures are going on, and we will try to address those as thoroughly as we can at the end of the lectures today. We really appreciate your attendance, and we hope that you're able to learn something with us here today. So without further ado, I'll go ahead and introduce our first speaker. That's Dr. Sydney Karnovsky. Dr. Karnovsky is a primary care sports medicine physician here at MGB, as well as a primary care physician at Mass General Brigham. Focused on the care of female athletes and runners, in addition to many other special interests. We're so happy to have her here today talking about sex differences in hip structure and function. Thanks, Dr. Karnovsky.
Thank you for the introduction. I'm going to share my slides. All right. So I'm going to talk about sex differences in the hip. I'm excited to give this talk. Like Dr. Borgstrom said, I'm a primary care sports medicine doctor with a focus on the female athlete. So this is a topic near and dear to me. I have no disclosures. And so the goal for today really is to talk about what are the differences in pelvic and hip structure between females and males, and then how does this contribute to symptomatic injuries and labral tears. So to start off, before we get to the hip, I want to think about sex-specific differences regarding hypermobility between females and males. As we know, hypermobility can cause people and patients and athletes specifically to have increased load on joints and soft tissues. And so patients, and especially athletes with hypermobility, are more at risk for soft tissue and joint related injuries. So it's very important when we're thinking about taking care of the hip in our athletes. And when we look at data, population data, we see that females are much more likely to have hypermobility than males based on Baton scores, which are a way that we can measure hypermobility in our population. Looking here at the differences between the female and male hypermobility scores, we see that at around puberty, the hypermobility in females gets much higher than that in males and tends to stay that way through the course of the lifespan. So we think that this probably has to do with the influence that sex hormones has on the mobility of our tissues, of our soft tissues, because we know that there are estrogen receptors and other hormonal receptors deeply interconnected and involved with our soft tissue structures. So when we're thinking about the hip, it's important to keep this in the background that when we're talking about the female hip, we're talking about a higher prevalence of patients with hypermobility to begin with. And then looking more specifically at the hip and the pelvis, it's always important to start out with the pelvic anatomy and how this differs by sex. And if you see in this picture here, which we have to give credit to Dr. Borgstrom for, this is part of a paper that she helped write. You can see just looking, with a playing eyeball, there's pretty significant differences between this picture A and B, which is a female pelvis and a male pelvis. And the reason is that evolutionarily, the female pelvis was designed to accommodate pregnancy and childbirth. And as a result, the pelvic structure is quite different. We have a wider pelvic structure, a wider sciatic notch, a wider suprapubic angle, increased distance, interspinous distance and intertuberosity distance, and a shorter pubic symphysis. So if you look at these two hips, structurally, there's pretty notable differences. And this leads to differences in the actual hip joint and the function and biomechanics and dynamic mobility of the hip joint. Looking at the hip joint specifically, there's a couple main differences I want to point out between the female and the male joint. The first thing, which I think is really important to how the joint functions and how the soft tissue structures around the joint function, is the femoral anteversion. And what this means is essentially how the femur, as it comes into the acetabulum, so as our ball and socket joint come together, it has to do with how the femur is tilted which then affects the entire lower extremity alignment. And in females, we see, looking across population-wide data, there's an increased amount of femoral anteversion. So an increased, tilt, then kind of changing the position of the femur, 16 degrees as compared to 11 degrees, based on some studies in the female compared to the male hip. And what this does is it changes the pressures of the hip joint. Not only does it change the pressures of the hip joint, but it changes the pressures of all of the tissues that are attaching in and around the joint. For example, when we think about how this affects the muscular control of the hip joint in the lower extremity, one thing we think about is the abductor muscles. So the gluteus medius being one of our major abductors. And we see that in the female hip, that structure kind of runs in this area. And in the female hip, looking at EMG studies, so muscular activation studies, there's a pretty significant decrease, so 30% decrease in amplitudes in activation of this major muscle as compared to males. And one large reason has to do with the positioning of the femur in the ball and socket joint. Another important femur-related difference in the female hip as compared to the male hip is the actual size of the femur and the size of the femoral head, so the size of the ball sitting in the socket. The average diameter in a female is about 30% less surface area than the male femoral head, meaning that the pressure of the ball socket joint, you're extending all the pressure of the body as you're connecting the upper body to the lower body on a much smaller amount of space. And so the joint loading and the forces across the joint are going to be distributed a little bit differently in the female as compared to the male hip. And there's higher opportunity for more pressure spread over a smaller space, which could potentially lead to higher chance of injury and higher chance of smaller things leading to major problems and things that cause longer lasting issues. And then the last part of the ball and socket joint is the acetabulum. So the area that the femur is sitting in, you have your ball in your socket. And when we think about risk factors for hip injuries and labral injuries and hip joint related pain, one thing we think about a lot is acetabular dysplasia. And so essentially a socket that's not quite the right shape, a socket that might be too flat and lead the ball to move around a little bit more, leading to higher rates of micro instability in the joint. And so then increased amounts of injury. And it's been reported in the literature that the chance of having acetabular dysplasia, so an atypical, not quite right socket joint in the female, can be as high as 5-to-1 female compared to male. So a pretty major risk factor in that as well. And so when you have all of these things that we've talked about, increased risk, increased chance of hypermobility, and then different angle of the femur, different amount of space that the femur actually sits in the socket, and more chance to move around in the socket, this leads the female hip to have increased range of motion as compared to the male hip. This has been reported in a number of different studies that looking at lots of planes of motion in the hip, external rotation, internal rotation, flexion, and abduction, the female hip has more motion on average than the male hip, pretty statistically significant. If you look at these numbers, it's pretty consistent that the female hip is having more motion on average than the male hip. And so what does all this lead us to? Well, it leads us to higher chances of hip joint related pain and injuries. And the thing that I will quickly touch on here is labral tears. Labral tears are extremely common in the overall population. Up to 40%, probably even higher. Asymptomatic young adults have radiographic imaging of labral tears, and we see it much higher in sports that involve significant ranges of hip motion, such as ballet, which tend to be female predominant sports. That being said, when we think about labral tears, what we really care is the people with symptomatic labral tears. And this is where we see the really big gender related difference. And we see females have sometimes reported as high as 3-to-1 likelihood of symptomatic labral tears compared to males. And despite reporting similar pain levels, we see much worse functional outcomes in our female patients than our male patients when we look at outcome scores and overall scores of hip function and hip symptoms. And so then we think, well, why is that? Is it maybe that we have all these structural differences in the joint, and so females are having larger labral tears or more chondral damage? And the interesting thing is the answer is actually no. When we look at comparing female and male labral tears, we see that labral tears actually tend to be bigger in males than females. And the cam deformity, which is a little bump in kind of the ball part of the ball and socket joint, which sometimes can lead to femoral acetabular impingement, thus causing labral tears, also tends to be bigger in males than females. But despite this, so despite the fact that the bump is bigger and the tears are bigger and there's more chondral damage seen in males, we still have more symptomatic and more loss of function in females than males. And so the question is, why is that? And the answer that I think, is kind of the overall summative answer is that it's a mix of everything we just talked about with the differences in the female and male hip and pelvic anatomy. The differences in the anatomy that lead to increased range of motion in females increases the chance of dynamic impingement and small amounts of micro instability in the hip joint, meaning that little things, even, little injuries or little ranges of motion that maybe extend past the normal are more likely to cause injury and dysfunction. And so there's a higher risk of having something that will irritate the joint because of the structural differences in the joint between female and male patients. And so it's important to keep in mind, when we're thinking about both non-operative and operative treatments, the differences in the female and male pelvic structure. And when we're treating a female hip, someone with anterior hip pain or soft tissue related hip pain in a female, we really want to take into account all of these factors and work on, treating the biomechanical dysfunction and working on neuromuscular control to help strengthen the hip and pelvis and correct some of the micro malalignment and micro instability, so that we can prevent these female athletes from continuing to be hurt and continuing to have lasting and disabling hip pain. So, really, I think take home points are that we can't look at a female pelvis and a male pelvis the same way. There are differences in the structure and function, and these lead to different injury patterns. Both from a diagnostic standpoint, when we look at imaging, we can't necessarily say, oh, that's a small labral tear, there's nothing to do about it, because a small labral tear may be the cause of very subtle differences in the way the hip joint is moving and could become very symptomatic in a female patient as compared to a male patient who may have similar radiographic findings or similar exam findings without having some of the same symptoms. So it's very important to understand these biologic differences as we think about how are we going to treat these patients and optimize their care, both from a rehab standpoint and a preventative standpoint moving forward. I'll pass it off.
Excellent. Thank you so much, Dr. Karnovsky. Great talk. Our next talk will be from Dr. Scott Martin. We'll be focusing on surgical considerations for female athletes with FAI or femoral acetabular impingement and labral tears. Dr. Martin is one of our sports orthopedic surgeons at Mass General Brigham. He's the director of our joint preservation service. He's also the head team physician for the New England Patriots, who are currently in the playoffs. And he was kind enough to pre-record a lecture for us here tonight. So Dr. Martin is up next. Thank you.
I am Dr. Scott Martin from the Department of Orthopaedics and Sports Medicine at Mass General Hospital. My presentation is on surgical considerations for female athletes with FAI and labral tears. I have no disclosures. Gans first described FAI in 2003 as a pathomechanical abrasion process that leads to damage to the hip labrum and cartilage surfaces that can then lead to joint destruction when left untreated. FAI is common in both male and female athletes. Successful treatment requires early detection, and when surgery is indicated, addressing any impingement lesions and preserving the labrum and the chondrolabral junction. Results of published surgical treatment of FAI in athletes has shown 75 to 90% return to their previous level of competition. However, athletes must have realistic expectations for return. Some studies, such as this one by Boykin in competitive rowers, 85% of whom were female, revealed only 56% returned to competition after surgery. Pincer lesions are more common in females and range from cranial retroversion to global retroversion of the acetabulum with overcoverage. With pincer lesions, damage is usually confined to the labrum with little damage to the chondrolabral junction. Cam impingement is more common in males and leads to abrasive tearing of the labrum and delamination of the articular cartilage, as seen in these next slides. This 18-year-old female hockey player had a very large cam lesion, as seen here on the done lateral view of her hip. This is the MRA of the same female hockey player, which reveals delamination and shearing of the articular cartilage with the flap at the chondrolabral junction, as you can see here with the arrow. This is where the articular cartilage meets the labrum at the transitional zone. This is an arthroscopic view of the same patient's hip, showing the cam lesion along with concomitant fraying of the labrum, which is to the left of the cam lesion bump. Demonstrates hip flexion of the same patient. Note that the cam lesion is elevating the labrum and entering the joint underneath it, eliminating the labral seal of the patient's hip. The arthroscopic view of the central compartment of the same patient, revealing significant damage not only to the labrum but also to the adjacent articular cartilage of the hip, noted by the black arrow. Female athletes usually have a milder morphologic abnormality. They are more susceptible to physiologic impingement of the hip due to decreased muscle mass along with increased laxity and motion, especially with hip flexion and internal rotation. Female athletes with femoral acetabular impingement are more likely to have a lower level of activity than males, with less anatomic abnormalities, less combined type of FAI morphologies, and less extensive articular cartilage damage than male counterparts. Female athletes are also more likely to present with profound symptoms, including increased pain, increased motion, increased laxity, and increased disability, resulting in lower functional scores. However, most studies have shown equal functional gains of female athletes, that is equal to males, by 2 years post-op. Female athletes, beware of other causes of hip pain that may mimic FAI and lead to false positive findings. These findings mimicking hip FAI and labral tears include stress fractures, ovarian cyst, endometriosis, SI joint pain, and iliopsoas symptoms. In a study by Astroni, the incidence of the psoas release was 46% in females compared to 2% in males. Also, beware of a labral sulcus, rarely found in males, that can oftentimes be misinterpreted on MRI as a labral tear when the underlying problem may be more subtle, such as hip dysplasia or occult instability. Surgical planning for acetabular recession for pincer lesions in females, consideration should be made of overall coverage, realizing that females are also more likely to have hip dysplasia, and over-resection can then lead to instability postoperatively. MRI with an anesthetic arthrogram, when combined with a good clinical evaluation, can be very sensitive and specific in diagnosing labral tears and chondral lesions. However, false positive findings can occur, especially in young athletic females such as this athlete with what appears to be a labral tear, noted by the white arrow. This is an arthroscopic view of the same patient, revealing a hip sulcus which can fill with dye during an MRA and appear to be a tear. Note the smooth edges of the labrum and its attachment site to the acetabulum, with no tear. When patients have failed conservative treatment with physical therapy and avoidance of painful activities for 3 months, then surgery may be indicated. This is an arthroscopic view of the central compartment of the hip, revealing a significant tear of the labrum and a chondral flap on the left. Reconstruction of the labrum and chondrolabral junction in this patient is then shown on the right part of the slide. This is a case presentation of a 19-year-old female athlete who plays both soccer and baseball. She first noted pain in her right hip 18 months prior to seeking medical evaluation. She describes her pain as both sharp, especially when pivoting and kicking during soccer, and also an achiness, which she describes as 24/7. She failed conservative treatment, and the pain was now affecting even her daily activities. Photographs revealed a cam lesion at the head-neck junction, best seen on the left done lateral view of the hip. Her MRA was positive for a labral tear, best seen on the left cross-sectional view and also on the right oblique sagittal view, indicated by the white arrows. This is the arthroscopic view of her hip, demonstrating a disheveled labral tear seen on the left part of the slide, and her femoral head is on the right. For this patient, arthroscopic repair was carried out for both the labrum and the chondrolabral junction. It demonstrates repairing both the labrum and the chondrolabral junction, which must be preserved during surgery. The femoral head is on the right side of the slide. Because of the extent of her injury, bone marrow aspirate with stem cells were also added to enhance the healing. This slide shows the completed repair of the labrum and the chondrolabral junction with application of the megaclot to the area of the repair. This is the arthroscopic view of the peripheral compartment of the hip, demonstrating the cam decompression with elimination of the impingement caused by the bump at her head-neck junction. The athlete was able to get back to baseball at 6 months, and she returned full to soccer at 9 months. Thank you very much for your attention.
Sorry about that, everyone. Just unmuted myself. Thanks again to Dr. Scott Martin. Next up, we have Dr. Emily Doolan-Roy, sports physical therapist extraordinaire here at Mass General Brigham. She will be speaking to us this evening about sports rehabilitation for the female athlete with hip pain and hypermobility. Thanks so much, Emily.
Great. Thank you, Dr. Borgstrom. So speaking about female athlete with hip pain and hypermobility. I have no disclosures. So a quick review of the dynamic stabilizers in the hip. I like this diagram from Newman in 2010. It's an old article, but it's a really good review article that goes through a lot of the hip mechanics. And I like this middle picture showing what direction each muscle is pulling in to help us think about the impact of each specific muscle. When we're thinking about hypermobility versus instability, it's important to note that an athlete with hypermobility doesn't necessarily have instability. So hypermobility is the increased mobility at one or more joints. And then instability is recurrent dislocation or subluxation, whereas micro-instability is when symptoms appear from the hypermobility, but not to the level of full dislocation or subluxation. So the level of hypermobility and instability are not directly related, and making sure that we have good muscular strength and motor control and proper mechanics can help to make sure that a hypermobile joint is a stable joint. I like this diagram from arthroscopy that incorporates a lot of the components of microinstability. You can see in the middle, it's talking about how capsular and ligamentous changes, bony deficiencies, and labral pathology all combine to contribute to microinstability. And you may have one or two of these, or you may have all of them together. And then you can see on the right a lot of the common imaging findings that we heard from Dr. Karnovsky. When someone has microinstability, they're often presenting very similar to how someone with FAI would present. They're reporting activity-related groin pain, worse with flexion and rotation. They may have a sense of giving way or buckling. They often have pain and hyperextension. They may have psoas tendonitis, and they can, I would say more often than not, they have an insidious onset, but there can be trauma as well. So the mainstay of this to start with is conservative treatment. With conservative treatment, we are going to look at activity modification, which may include avoiding end range positions, limiting provocative activities, and potentially participation in their sport if needed for a brief period of time. And then limiting passive stretching. Hypermobile athletes typically feel like they need to stretch all the time, but that is usually worsening the problem. That need to stretch often comes from, or that feeling of tightness often comes from a weakness. So instead, we need to make sure that we are strengthening them. Strength will focus on the glutes, deep hip rotators, adductors, and core. We're also including proprioceptive training, soft tissue mobilization, and in some limited cases, joint mobilization. The joint mobilization often will not focus on the hip joint, but rather the pelvis to make sure that they have a neutral pelvic alignment. We don't want to be mobilizing a hypermobile joint. There's a lot of studies looking at glute strength and what are the best exercises to achieve glute strength. Unfortunately, most of them do not have a common consensus. There's agreement of some that are better than others, but there's a lot of different exercises and a lot of studies that show one being better than the other. The ones that are bolded on the slide are systematic reviews, so that gives us a little better sense of what direction to go in. So this diagram is from the Raymond article, and it shows that the forward step up by far has the greatest glute muscle activation, glute max muscle activation based on percent MVIC. So the percent of the muscle fibers that are contracting with an exercise. This next slide looks at glute med, looking at the same thing using MVIC. I want to point out in this that if we look at the clamshells, those are down here at less than 40% muscle activation. So this tends to be one of the most commonly prescribed exercises, but is not actually the best exercise for getting glute med activation. In this systematic review, they found that the side bridge to neutral, so a side plank with a dip, and then returning to neutral is the best exercise. And then single leg squat, single leg deadlift, pelvic drop, and side-lying hip abduction were also fairly high in that study as well. When we're looking at these studies, we want a minimum of 40% MVIC, but typically aiming for closer to 60%, and the higher being better for these exercises. So taking all of those studies together, the most commonly appearing exercises with higher MVICs, for glute med, it's the side plank hip abduction, single leg squat, single leg RDL, side lying hip abduction, pelvic drop, single leg wall sit, transverse lunge, and single leg bridge with a band. The glute max is the split squat, step up, single leg RDL, single leg squat, wall squat, transverse lunge, and single leg hip thrust. And then the items that are starred on this appear in both the glute max and glute med list. So are good exercises if you're trying to minimize the number of exercises you're giving a patient to get both glute med and glute max. Then it's really important with all of these exercises to make sure that we are loading appropriately. These studies, MVIC, typically are based on a 12 rep max. So we want to make sure that we are loading it to the point where when they get to 12 reps, they feel like they need to take a break. If they can do more than 12 reps easily, then we need to add more load. Moving on to core strength, we want to make sure that we're focusing on transverse activation and oblique activation without an overuse of rectus abdominis or hip flexor. Making sure that we're really palpating patients and ensuring that they're using the proper muscles. We want to make sure that we're working in a neutral spine, not just a posterior pelvic tilt. A lot of core exercises, patients are being cued to flatten their back into the table. That can be appropriate for some exercises, but we also want to make sure that we're working in a neutral spine, which is where the athlete will be doing a lot of their activity as well. And then thinking about where the athlete is working, make sure that you're progressing to standing positions or sport-specific positions. Most people are not doing their sport on their back, so make sure we're progressing to higher level exercises. For proprioceptive training, there's a lot of options of what you can do. One thing that I really like is using the laser that we commonly use for cervical joint retraining and attaching it to a patient's leg or to their waist. If it's on their leg, you can have them follow a maze, trace out letters on the wall, anything to know exactly where their leg is in space. And then I like putting it on the waist where you have them march in place, trying to keep the laser focused on a target on the wall, trying to stay as stable through their pelvis as they can, activating glute med to minimize that pelvic drop. And then thinking about balance, again, we want to make this as sport specific as we can. So with dancers, putting them on a wobble board, whatever the athlete is, try to put them in their most sport specific position as possible, starting with a stable surface and then progressing to unstable, eyes open to eyes closed, and try to have some fun, make this a little bit more exciting for athletes. And then it's also really important to consider end range strength. Often athletes feel the least stable when they're at their end ranges. So making sure that we're incorporating strength in these positions as well as they're able to tolerate it. This won't be our first exercises that we go to, but as they're getting back towards their end stages and return to sport, we want to make sure that they're strong everywhere that they need to be. And then this is the glute strength, and the proximal strength is the mainstay of what we're doing, but it's also important to consider the pelvic floor, foot strength, tibial alignment, and neurodynamics as other potential causes that can be contributing to their symptoms. And then if this isn't getting us where we need to, then we're moving on to consider surgical intervention and discussing this with the team of providers. So some take-home points: hypermobility does not equal instability. Conservative treatment should focus on strength, proprioception, and motor control. Not all exercises are equal, and make sure you're choosing the appropriate exercise with the appropriate load. And rehab should include sport-specific motions as well to get them fully back to what they need to do. Thank you.
Thanks so much, Emily. Really appreciate it. Next up, we have Dr. Olivia Wands, who will be talking to us today about psychological skills to aid return to sport in female athletes after hip injuries. Dr. Wands is a psychologist, really has been a big part of our growing effort to support our athletes in with sports psychology services through our women's sports medicine program, and we're just very happy to have you here today. Thanks, Dr. Wands.
Okay, well, thank you so much for inviting me to be here today. As Dr. Borgstrom mentioned, I'm a clinical psychologist in the Women's Sports Medicine program at MGB. Looking forward to sharing with you all some information and work my team is doing related to psychological considerations in female athletes with hip injuries. So I have no disclosures to report. As many presenters have already touched on, hip injuries are quite common in female athletes. And so when we think about why hip ingrown injuries are so common in females, we need to think about several different risk factors, as it's rarely just one thing that increases risk. So, high demand sports that involve a lot of cutting, pivoting, sprinting, and extreme hip motion can carry higher risk. That risk can be amplified by various biomechanical factors like joint laxity or pelvic structure, which some other folks have touched on, biological factors like low energy availability, and psychosocial pressures, especially the expectation to play through pain. And so the last two I'll be focusing a bit more on in today's talk. And so while being risk factors for hip injuries, these same factors can really heighten or impact stress, fear, self-doubt, and confidence, which can really shape how athletes perceive pain, recover from injury, and return to sport. So beyond the physical injury, hip injuries can create pretty significant psychological stress, including things like fear of re-injury, loss of athletic identity, and emotional distress, especially when recovery is slow or unpredictable, as I'm sure a lot of folks have experienced when working with athletes time to time. And so uncertainty about return to sport, and the pressure to push through pain, and obviously reduced trust in the body are also common experiences that athletes can have that can serve as psychological stressors. And it's important to note that appearance-related pressures, which actually is on this slide. I just want to touch that there's also this broader cultural context of psychological stressors that I wanted to take a second to note in addition to what I just talked about. And so it's quite important to note that the appearance-related pressures shown here in some of these statistics, such as pressures to maintain a certain body type or conform to gender norms, those exist regardless of injury. However, these pressures can really intensify during injury and recovery process, and sometimes encourage things like underfueling and increased risk for delayed healing or re-injury, which I'm going to get a bit more into on this next slide. So I wanted to take a moment to highlight relative energy deficiency in sport, or otherwise known as RED-S, and low energy availability, and their role in an athlete's psyche when going through a hip injury and recovery. So in simple terms, both of these terms mean that an athlete isn't eating enough to meet the demands of training, recovery, and sometimes just their daily life. And so the presence of these can really increase vulnerability to eating disorders. And as I mentioned, increased risk for delayed healing or recovery. And I wanted to touch on this a little bit as being part of the psych team. We are working with a lot of folks going through hip injuries, other injuries who are presenting with disordered eating due to RED-S or LEA existing. And so when RED-S or low energy availability or an eating disorder are present during a hip injury, it's a sign that the body doesn't really have the fuel it needs to heal. And so as a result, athletes can experience many negative side effects, including prolonged pain, recurrent symptoms, slower return to sport, and we see a lot of increased fatigue as well. And so psychologically, this often shows up as things like low mood, irritability, increased fear and hypervigilance around the hip symptoms that they're having. And also we see a lot of rigid beliefs that fueling can lead to weight gain, or that by them taking rest for their injury, that's a sign of weakness. And each of these different types of unhelpful beliefs can certainly interfere with their overall recovery. So given some of these consequences and the risk for developing, especially an eating disorder, if these things are present, it makes early screening and intervention for underfueling really quite important during the injury recovery process, and even diagnosing the injury itself at the start. So given the range of psychological stressors that can emerge during a hip injury and recovery, interventions often do need to target more than just the hip. So especially some of these psychological stressors that I've talked about. Some key intervention areas include things like reducing fear and gradually rebuilding confidence through exposure, or providing pain education to decrease hypervigilance around symptoms, and also supporting psychological readiness for return to sport. It's also critical, as I touched on, to really be screening for underfueling and address any unhelpful beliefs that might be coming up about whether it's fueling, rest, body image, performance, and doing this really all within a coordinated interdisciplinary approach to care. And so in treatment, we tend to focus a lot of our work in my group on a few core components. So the first is education. We really try to help athletes understand that overtraining, recovery, sleep, the developmental transitions, and things like low energy availability are all really important when we think about injury recovery. We also do try to address nutrition and fueling mindset by assessing different beliefs and behaviors related to food and collaborating with sports nutrition when needed as well. And then from a more like cognitive, emotional perspective, we work on skills like mindfulness, thought reframing, graded exposure to feared movements, and acceptance-based coping strategies to help support both recovery and the return to sport. And then lastly, we also support athletes' development of non-athlete identities, as when they're going through an injury recovery and not often participating in sport, it's a good time for them to be exploring some other areas that might be important to them. So our team has been working to develop some modularized handouts to address some of these key intervention targets. And so I'm going to show you all just a few examples of treatment materials we've developed so far and are using to target some of these key targets that I've just reviewed. So first and foremost, psychoeducation, I shared it's a critical part of our work. And so these are just some examples of psychoeducation handouts that we often use. So the handout on the right focuses on low energy availability, which this information is really to just help the athlete understand what underfueling is, how it can present in their life, and why fueling matters so much for healing, and also just different signs that athletes can look out for in themselves in case it is something that they're experiencing. And then the handout on the left normalizes really that injury recovery, especially for something like a hip injury. It's rarely linear, and this information is really a tool that will help some athletes reduce fear, frustration, and self-blame when setbacks occur, which we all know are quite common, if not inevitable, experiences for athletes going through recovery. And this slide is just highlighting some of how we approach nutrition from a fueling mindset rather than a restriction mindset. So we focus on helping athletes understand that food is fuel for training, recovery, and healing, especially during the recovery process. And so we use some practical tools like busting preconceived myths about fueling as an athlete. We'd go through personalized fueling plans to help athletes structure their day in terms of when they'll eat and how, and then clear guidelines about eating enough to help reduce confusion. And all of this is often supported with nutrition guidance as well. And then lastly, this slide just shows an example of how we use some cognitive restructuring during injury recovery. So athletes with hip injuries often can fall into some common what we call thinking traps. So just different thought patterns where they get stuck. Often things like all or nothing thinking, catastrophizing, so kind of assuming the worst, or judging themselves unfairly. It's quite common when progress feels slow or inconsistent for the athletes. And so we try to help them identify these patterns and practice more flexible, balanced ways of thinking, which we find can reduce stress, improve coping, and help support their confidence as well. So lastly, just some key take-home points. So overall, female athletes with hip injuries, they face some pretty unique psychological challenges between RED-S, low energy availability, eating disorders. All of those things can increase the risk of injuries and can delay healing, which is, once again, making early screening of behavioral health patterns really important. And then evidence-based tailored programs that integrate both sport and clinical psychology interventions and skills with an interdisciplinary team are going to support better recovery. And lastly, it's just that this is a really unique population with unique needs. And so addressing mental health and physical health and well-being throughout the whole injury recovery process is central to both their recovery and future performance. And then I just want to thank you again for inviting me to speak today, and just a special thank you to some of the other team members that have contributed to some of the work I've talked about today.
Wonderful. Thank you so much, Olivia. And finally, for our last talk, we have our second, but also wonderful Olivia Morgan, who is a registered dietitian and sports nutrition expert here at MGB. She's going to be speaking to us this evening about nutrition considerations in hip and pelvic bone stress injuries in female athletes. Thanks so much, Olivia. All right. Get these queued up. All right, everyone. So I'm going to talk about one of my most favorite topics, which is bone health overall. So when we have an athlete who has experienced a hip pelvic bone stress injury, there's basically four main considerations that I am going into the appointment with. I'm thinking about energy sufficiency. So is the individual meeting their energy needs? Are we meeting our macronutrient or micronutrient needs? And are there any nutrition-related labs that we need to consider? I take all of that, and then we're also thinking about how we can prevent these injuries in the future as well. So as Olivia Wands mentioned, energy sufficiency is absolutely the most paramount when it comes to nutrition and bone health. We know that we want to ensure that we are obtaining optimal energy availability, which on a clinical basis means that we're providing over 30 kcals per kilogram of fat-free mass. In a more clinical situation, that means that we're calculating energy needs, usually using some sort of equation. Often in the outpatient setting, we're using Mifflin-St. Jeor with the use of an activity factor. When I'm interviewing an athlete, I take a significant amount of time discussing with them
all of their activities that they are participating in, because we want to make sure that we are accounting for any activity that they are doing. So that means not just their intentional movement, their sport, but what is their activities of daily living looking like? Do they work in a very active job? Do they have to walk to work? Do they have to be chasing around two young children throughout the day? Those are considerations that we have to take when we're thinking about that whole picture of energy sufficiency. Another piece is just, our energy needs for healing. When individuals are not able to fully participate in their usual level of activity, they can often become quite concerned. Oh my gosh, am I going to gain weight? But we do need to also take into consideration how much energy it takes to heal such a large bone. When I'm looking at an athlete's daily intake, I'm usually taking a 24-hour diet recall. So just kind of going through a typical day of eating and looking for some specific patterns. I'm looking to see, are individuals eating consistently throughout the day? How are our nutrients broken down at those intervals? And are we fueling before and after our intentional movement? I take special consideration for our pre-exercise fueling. I have many athletes who have acquired significant bone stress injuries by participating in fasted training, especially, working out first thing in the morning on just a cup of coffee, and going through the rest of their day, pretty highly underfueled. So just kind of setting themselves up for a negative situation. We know that optimal bone health, our bone turnover, optimal bone growth only occurs whenever we are meeting all of our energy needs. So being really, really cautious with this particular point. Then thinking about our macronutrient breakdown throughout the day, protein is the most talked about thing in the entire world right now. And because of that, nobody cares about carbs anymore. Carbohydrates are the most underappreciated component of bone health. One really interesting component of the most recent IOC consensus statement on relative energy deficiency in sport was that they found that in individuals who are consuming sufficient calories but not consuming sufficient carbohydrates, they did not have as effective of bone turnover as the individuals who were consuming sufficient calories and sufficient carbohydrates. So it really points to, we don't just have to meet our total calorie needs. We have to make sure that we're being aware of our macronutrient distribution throughout the day. And you can see that carbohydrate needs are very directly changing throughout the course of our training. So when athletes are going from, building in a training block, doing 1 hour of exercise, to then going up to, doing a 16-mile long run on the weekends, we know that our carbohydrate needs do change throughout that time. Another macronutrient that we need to consider specifically for our female athletes is fat. Sometimes it can be easy to make some assumptions when individuals are going through a diet recall that they are adding fat to, let's say, roasted vegetables, for instance. But unfortunately, that's not always true because people are very concerned about aesthetics and weight, and they may be making sacrifices, especially with fats. Fats are extremely necessary for hormone production. We need to ensure that athletes are getting sufficient fat to support that part of our health. Then thinking more about that micronutrient piece, I am only ever really thinking about calcium, vitamin D, and iron. I'm not really thinking more about vitamin K or magnesium or zinc, which can generally be met with a well-balanced diet, which many athletes are making an effort to consume, a variety of different foods that have those pieces. Thinking about calcium, to meet needs with food alone, we need to ensure someone is having 3 high calcium foods a day, which is relatively significant. This is called the rule of 3. So basically we have 3 high calcium foods and then in combination with a balanced diet, because there are little drips and drops of calcium in various foods that we're consuming. If an individual is not able to kind of reach that point of calcium intake, then we do need to turn to supplementation. The problem with supplementation is that we need to make sure that we're spacing it out. And we're being conscious of factors that limit absorption, including caffeine, supplements that contain iron, and any high phosphorus beverages like colas. Vitamin D is of particular concern for us living in New England area where we have very little sun exposure. So most individuals are requiring some vitamin D supplementation. So the food sources are very limited, and as you can see, it's a very small total amount of vitamin D that's in those foods. And then finally, iron. Iron is especially important for our female athletes. We know that, we're losing iron more than other athletes, and it can very much affect our bone health. And this is a little bit more of a challenging piece to kind of navigate, just because it's not always a straightforward line of, if we need to supplement iron in all of our athletes, it's usually that we need to ensure that we're checking our serum values, to supplement appropriately. So usually I'm looking at vitamin D and an iron panel as well as ferritin, kind of looking at the storage forms of iron. I will often request for a physician to check vitamin B12 as well for individuals who are a little bit more at risk. So people who are vegan, vegetarian, taking a PPI. It also just kind of gives a better, well-rounded picture, especially if an athlete is also, noting that they're fatigued pretty, consistently. For vitamin D, we're looking for a slightly higher serum level. We've broken a pretty large bone. We need to kind of hedge our bets and make sure we're doing what we can. And with iron, for female athletes, we want to aim for a ferritin level that's greater than 50. Usually, if it's below 50, I'm adding some sort of supplementation. If it's pretty significantly below, then we're adding a little bit more of that supplementation. I am more in favor of trying to go with oral supplements versus going straight to infusions, because I think that kind of gives us a band-aid to the situation. We need to maybe look at the root cause for individuals. The tough thing about iron is we need to ensure that the athlete is not in a state of inflammation. So we'll often check a CRP at the same time, because ferritin can be falsely elevated. I've even had athletes who got their labs checked when they had a cold, and the ferritin was elevated, when in fact it wasn't actually truly elevated. So just thinking about how we can put all these pieces together and move forward to prevent future injuries, we want to think about our energy sufficiency. Are we eating enough to meet all of those energy needs and support that basically luxury item, which is bone turnover? We need to make sure that we are adjusting our intake as training changes. A lot of people fall into food patterns and we kind of eat the same things consistently. We need to adjust that intake as we train more. We need to think specifically about carbs, how often we're eating carbs, and prioritizing our pre and post-exercise fueling. Calcium, we can't forget our calcium intake and maintaining at least 3 high calcium foods a day, and then monitoring any need for supplementation with something like vitamin D or iron as well. All right, thank you so much.
All right, that brings us to the end of our lectures for today. Again, thank you to all of our speakers. We will now segue into a Q&A panel discussion. And again, if there are any live questions, please feel free to chime in. First, I just wanted to start out with a question for Sydney. So Dr. Karnovsky, both you and Dr. Martin kind of talked about labral tears, you talked about extra-articular pain generators. Any clinical pearls that you have for us tonight on ways to kind of tease out extra-articular versus intra-articular on your exams?
Yeah, that's a great question. I think intra-articular, I think it was Emily that might have mentioned, it's really athletes that are talking about groin pain in certain, motions, specifically motions of deep flexion and deep internal rotation. If they're starting to point to their groin, and I often find it's pretty non-specific, they'll just kind of point to the front of the hip and maybe trace a line from like the groin all the way out to the lateral aspect. That's usually a pretty good indicator in my mind that this is more likely going to be an intra-articular than an extra-articular source. Whereas athletes are where if they're talking about, really pain on the outside of the hip and they're pointing to, more of the bony prominences, either the greater trochanter or the ASIS, where we have some of our soft tissue attachments. And they're talking about pain that gets worse when they're sleeping and when they're lying on their side. That tends to point me towards that extra-articular direction. And so I think, clinical pearls, the biggest, first takeaway is what they're telling you in their history. And then that can give you kind of a background as you go into the exam. And in the exam, when you really think about intra-articular, it's really those deep flexed and internally rotated positions that tend to irritate them, whereas it's more of the side lying and, abduction type positions that irritate the extra-articular structures. So it's usually what I think about.
Excellent. Yeah. And with your background, Dr. Karnovsky, and your special interest in kind of women's reproductive health, and Dr. Martin had brought up, mimickers. And one thing he brought up was endometriosis. Obviously, many other kind of intrapelvic, or GYN potential contributors. How often have you seen kind of a GYN issue masquerading as, a hip issue?
Yeah, I think less commonly, it's not something that comes up all the time. The one that I've seen the most commonly is large fibroids, and very large fibroids that are more laterally located. I've seen sometimes not being diagnosed instead of maybe an intra-articular pathology, but sometimes we'll get an MRI and we'll see both. And we'll see there's some intra-articular source, but then also a large fibroid that may be contributing to general pain in that area. And a couple of times I've seen those large fibroids actually progress to being removed. And it's hard to know if that or the physical therapy they're doing for the hip is the ultimate solution. But I do think it comes up sometimes. Fibroids and endometriosis are probably the most common, but not super commonly.
Yeah, I agree. Just important to kind of keep it on our radar, and if something isn't adding up, to make sure to kind of dig deeper, or reach out to a colleague for help. Emily, anything to add from kind of an exam standpoint, clinical pearls that you've found, maybe specifically related to athletes that you see go on to needing surgery? Like, is there anything that you identify or have seen that kind of predicts progression to surgery in these athletes with labral tears?
There's not as much necessarily on my initial eval, but sometimes on the initial eval, if they come in and they have great strength, and their pelvic alignment is good, their motor control looks pretty good, and they're still having high levels of pain, that makes me a little bit more hesitant of how successful PT will be. Typically, that's not what we're seeing. So we're starting out with strengthening and exercises to improve motor control, all of those things. But then if they're not improving fairly quickly and linearly as their strength improves, then I'm going to get another person involved pretty quickly, make sure that they're seeing someone else, and starting that pathway.
Excellent. And just to emphasize this point, like, how often are athletes coming in? Do you find that they're weak through their core and their hip abductors?
99% of the time. So whether that's what makes them symptomatic, whether that's, even asymptomatic people, we can often find weakness as well. So sometimes we question how high is our standard, and how good does someone need to be to meet our bar. But I would say the vast majority of patients that come in, we're finding weakness, particularly in the glute med and in the core, often glute max as well.
I think that's such an important point. You have a lot of athletes that come in that feel like they're very, very strong, and you can be globally strong, but have significant deficiencies in some of these really important stabilizing muscles. In the clinic, I think it's important. We don't always have a ton of time with patients, but taking a minute to do a single leg squat or something to really show the patient that they have some room for improvement, I think can help them buy in, to a good course of sports PT, where you guys can then do a much more, kind of detailed assessment and fine tune that treatment. But just a plug for, a screen in the clinic that can help the athlete get a sense that they do have some room for improvement. Very good. Thank you so much. Olivia Wands, question for you. Great talk, talking about kind of beyond the physical, implications of injuries. One thing that comes up not terribly infrequently with my female athletes who are dealing with hip injuries is sexual dysfunction, and I think it's not really like talked about a lot. How often does that come up for you when you're managing hip injuries and kind of the psychological implications or kind of beyond the physical?
Yeah, that's a great question. I'm going to be totally honest, it really hasn't come up. And we will do, I mean, depending on, ages of folks that we're working with, do screenings of like sexual activity, but not something I guess has come up. I can think of female athletes I've seen with other injuries who also might be in like pelvic physical floor therapy for pain. Um, during intercourse, but it's separate, I guess, from hip injury. So I haven't seen the crossover yet. Um, but that does strike me as a potentially really good opportunity to coordinate care as well between psychologists and PT potentially, as I imagine that there could be similar concerns coming up across like both disciplines.
Yeah, absolutely. And then just another quick follow-up question on, you kind of comment on using the period of kind of injury recovery to grow non-athlete identities. How do you do
Mhm.
that?
Yeah. First is kind of helping athletes explore like what are you outside of being an athlete? Because typically the first question when you ask an athlete is like, who are you? They say, oh, I'm a soccer player, or an athlete, and they don't say much else. So it's kind of helping them see that they also have identities as, sister, friend, student, neighbor, artist, all sorts of other things in their life that they don't necessarily see as um, like important traits to them. And so, because they're so laser focused on their athletics. And so, kind of helping them take a step back from their sport and see that they have so many other qualities and characteristics that make them who they are. And then the next step is really then how do we place value on those areas of life? Because right now it's like all their eggs are in the athlete basket. And so, kind of trying to redistribute those eggs to these other buckets of life so that if one area does come crashing down, like they can't participate in sport, they still feel like a whole person because they have these other areas of life that they value and are still striving to be, like the best version of themselves in those other areas of life.
I love that. That's great. And important for all of us probably. Olivia Morgan, I have a couple logistical questions. I know we're running really low on time. But when you're counseling an athlete who's like maybe needing some calcium, vitamin D, iron supplementation, logistically, how do you tell them to do that in their day with, kind of interactions and things like that?
So usually it's you take iron, you turn over in the morning, you take iron first thing throughout the day. I usually encourage people to try and get at least two high calcium food sources throughout the day and then take one calcium supplement in the evening to make up for that like remainder that we maybe aren't getting from food. So then we're doing the iron first thing. That's maybe getting in the system before we're taking our sips of coffee first thing in the morning. And then the calcium is kind of closer to bedtime. Calcium can also cause some like constipation, GI issues. So I find that it is a little bit better in the evening. If someone does really have GI issues, then we go to calcium citrate because it tends to be better tolerated than calcium carbonate.
Excellent. That's super helpful. I think we'll end the webinar here, and I'll just take a few seconds to really thank our expert panel. Wonderful talks, wonderful discussion tonight. Really so appreciative of being able to work with people like you and kind of grow our women's sports medicine program. And appreciate all of you, appreciate our audience, and really thank you to Arthro School for serving as an educational platform for tonight. Thanks again, and hope everyone has a great day or evening wherever you are in the world.